Thank you, Anshu. So at the onset, I thank Anshu Kanmani for coordinating this IUP Trivandrum Zoom, IUP Trivandrum Journal Club very well, and I also thank the KIMS team who are doing the presentation today, and we are waiting for this academics to happen, and we are waiting for, and we have senior faculty Ram Kuti sir, Rajmohan sir, and Sulfikar sir also joined, and Padmanabhan sir from Canada also joined. So we are all waiting to hear from you, sir. So, over to Anju.
Thank you, sir. Dr. Padmanabhan sir, any opening words, remarks, sir? Padmanabhan sir? You're mute, sir.
Now you can hear me, is it not?
Yes, yes.
Yes, sir.
You
yes,
carry
sir.
on,
Sure.
carry on with the meeting.
Yes, sir. Yes, sir. Okay, sir. Okay. So we'll directly go to the subject proper. And today we have a very interesting topic. We are dealing with a newer drug, medicine, which is very important in pediatric epilepsy and seizures. So this drug is lacosamide, and what the details of its action, like action on voltage-gated sodium channels, and the discovery in 1996, FDA approved in 2007. It's available in India and all. Used in refractory epilepsy. So today we have a very novel, very recent article which has been published in neurology journal. And today the team is from KIMS Health, Trivandrum, and we have none other than Dr. Kalpana Madam, respected teacher and senior pediatric neurology consultant from KIMS Health. Madam is in the expert panel, and we have Dr. Karthika Ajit. Madam is a consultant pediatric neurologist from KIMS Health. The presentation is done by Dr. Pavan Kumar, and analysis is done by Dr. Nikitha. Both are doing the fellowship in pediatric neurology at KIMS Health. Without losing time, I would like to welcome all, especially Dr. Padmanabhan sir, Rajmohan sir, Ram Kuti sir, Sulfikar sir, Purushottam sir, and other teachers, seniors, and colleagues. Over to Dr. Pavan Kumar for the presentation of the journal. Over to Dr. Pavan Kumar. We can start presentation.
Yes, sir.
Start sharing the presentation. Yeah.
Good evening, everybody. I'm Dr. Pavan Kumar. I'm from KIMS Health Trivandrum. Today we are talking about an article with the title Long-Term Efficacy, Safety and Tolerability, including behavior and...
Excuse me, Dr. Pavan. Dr. Pavan, excuse me.
Yes, sir.
Sorry for interrupting. Can you be a little louder or nearer
yes,
to the mic?
Yes, sir. Yes, sir.
Adjust it. Thank you. Thank you, sir. Okay, take it. Please continue. Please continue.
The name of the article is Long-Term Efficacy, Safety and Tolerability, including behavior and executive functioning during adjunctive lacosamide treatment in pediatric patients with uncontrolled epilepsy. So introduction, epilepsy is a chronic disease requiring long-term pharmacological management, with approximately 25 to 30% of the children having uncontrolled seizures despite treatment. Children with epilepsy are at an increased risk of cognitive and behavioral problems, and some ASMs, just like levetiracetam, have been associated with cognitive and behavioral side effects. Lacosamide is an anti-seizure medication that selectively enhances the slow inactivation of neuronal voltage-gated sodium channels. Lacosamide is indicated as a mono or adjunctive therapy for focal onset seizures in patients more than 1 month of age and older in United States of America, and patients above 2 years in Europe. So the objectives of this study was to evaluate long-term efficacy, safety, and tolerability, including behavior and executive functioning during adjunctive lacosamide treatment. The age group is more than 1 month to less than 18 years of age with focal onset or generalized seizures, enrolled in 2 open-label long-term follow-up trials.
Dr. Pavan, sorry for interrupting again.
Yes, sir.
Dr. Pavan, sorry for interrupting again. Sorry to all. The screen is showing a small icon of the, at the lower right side. Can you see that? Can you remove it or minimize it? Yeah.
Yes, sir. Yeah. So the inclusion criteria is patients aged more than 1 month and less than 18 years, and uncontrolled focal onset seizures after an adequate course of treatment, and more than 2 countable seizure episodes in the 4-week period before the screening, and on a stable dose regimen of at least 1 to 3 anti-seizure medications. And the exclusion criteria was receiving any investigational drugs or experimental treatments in addition to lacosamide. Patients more than 6 years of age with a lifetime history of suicidal tendencies and suicidal ideation in the past 6 months. Patients from previous lacosamide trials, patients with previous history of adverse effects to lacosamide. So the methodology is an analysis of pooled data from 2 trials, SP848 and EP0034. So SP848 was a phase 2 multi-center open label extension trial to evaluate the long-term safety, tolerability, and efficacy of adjunctive lacosamide. It was initially designed as an open label trial for pediatric patients greater than 1 month to less than 17 years of age with focal onset seizures. But it was later amended to open to patients from other pediatric trials of lacosamide in focal and other epilepsy syndromes, along with an addition of 200 eligible pediatric patients with focal onset seizures who have been enrolled directly and who have not participated in any other previous clinical trials. And in the SP848, the maximum duration of treatment was 2 years. The other trial is EP0034, is a phase 3 multi-center open label trial. So in this trial, the other 2 trials, the above SP0967 and SP0969 were a double-blind trials of phase 2, which were then combined to phase 3 trial in EP0034. And this has a similar inclusion and exclusion criteria with 2 years duration of treatment. And in both studies, the maximum dosage was 12 mg per kg per day or 600 mg per day, whichever was lower. So the outcomes of the study, so endpoints were assessed for the trial pool data. Retention was measured using Kaplan-Meier estimates. Efficacy and so the Kaplan-Meier estimates are used to estimate function from time to event data, provides an estimate of survival function, which represents the probability of an event. So this actually avoids the censoring. So during any trial, there we might lose individuals to follow up, or they might leave the study due to various reasons. So this Kaplan-Meier estimate shows the amount of people in the charts that. So the next one is retention was measured. Efficacy endpoints were median percentage reduction in focal onset seizures in various subsets, and clinicians and caregivers' global impression of change. So here we can see the clinician and so the clinician and caregiver's global impression of change is an assessment scale. Both are subjective global assessment scales. Are standardized tools used in clinical research and practice to assess patients' overall change in condition over time. So it assesses the patient condition, whether it has improved or worsened related to a baseline state, and the baseline state being at the start of the clinical trial. So whether we check whether using a questionnaire whether the patient has improved or not, and it comes from both the clinician's perspective and the caregiver's perspective. So it is a scored. A score is given with around 60, say around 70. So depending on the score, whether we can have the worsening or the improvement, we can be checked. The safety and tolerability endpoints for treatment emergent adverse effects, behavior and executive functioning by Achenbach child behavior checklist and brief. So the Achenbach child CBCL is one of the most widely used standardized tools for behavior and emotional problems in children and adolescents. So its main purpose is to identify emotional and behavioral problems, monitor changes over time in response to interventions. Example, for this clinical trial, we are doing an intervention, and support diagnosis and further treatment planning. They provide a standardized data that can be compared to normative samples. Again, the CBCL has 2 versions for 1.5 to 5 years of age group and 6 to 18 years for school-aged and adolescents. And the next one is quality of life was assessed using pediatric quality of life inventory. So this was the child behavior checklist CBCL for 1.5 to 5 years of age. It is scored around 70, between 65 to 70 being diagnostic and 60 to 65 being borderline. So there are various questions depending on the age group of the child, and it is usually filled by the caretaker. So coming to the statistical analysis, retention, safety, and quality of life were assessed in the safety set, which was defined as all the patients who took more than one lacosamide dose in either trials. And efficacy was assessed in full analysis set, which include all the patients in the safety set who had more than one completed post-baseline seizure diary. And for seizure analysis, complete cohorts were defined as subsets of focal onset seizures who received lacosamide for a specific duration of time. The cohorts are divided into 6 months, 12 months, and 24 months, where a 1 month was defined as 28 days and has seizure diary data available for the specified interval. So, and seizure freedom was defined as 0 seizures reported and no more than 10% of the days in the specified completer cohort or time interval for which seizure data were not available. So, coming to the demographics, so around in the total number of patients, around 54.8% were 4 to 18 years in focal onset, and 55% were 1 month to 4 years of age. And in generalized seizure population, around 5% of them. The seizures were divided into partial onset seizures like simple partial, complex partial, and partial evolving. So the total number of focal onset seizures and there were 851, and for all out of 47 were generalized seizure population. And depending on the number of ASMs that they are taking, less than 2 and more than 2. And the common anti-seizure medications that they were taking were valproate, levetiracetam, and topiramate. And other medical conditions that are present in patients, mental retardation, cerebral palsy, and developmental delay, around 12.3% in mental retardation in focal onset seizure and 11.6% in total population. Cerebral palsy is around 9.5% and developmental delay 6.1%. These medical conditions are only present in focal onset and not in generalized seizure population. And coming to the results, a total of 905 patients were included in the pooled subset, and 901 patients were included in the function analysis set. Patients had a mean age of 8.2 years and 54.8% were male. On average, patients had an epilepsy duration of 4.9 years. Overall, 536 patients had more than one comorbid condition at the trial initiation. And the overall completion rate was 71.7%. The proportion of the patients completing the trial was numerically higher in generalized seizure population than focal population. The reasons for discontinuation were around in focal onset seizure, around 5.2% discontinued due to adverse effects and 10% due to lack of efficacy. And in generalized seizure population, around 6.4% discontinued due to adverse effects and 8.5% due to lack of efficacy. And around 10% in focal onset due to withdrawal by the patient and 4.3% in generalized seizure population. Retention, and around by the end of 1 year, almost 80% of the patients were retained in the study, and only 8% have discontinued due to lack of efficacy and 5% due to adverse effects. This shows the Kaplan-Meier curve, where it shows around 72% in the first A diagram. Around 72% were retained at the end of the study at 672 days, that is 2 years, and around 90% due to lack of efficacy. Only 10% were lost due to lack of efficacy, and around 4%, 95% were retained, and 5% were lost to adverse effects. At baseline, patients in focal onset seizure population had a median seizure frequency for 28 days of 12.5% for focal seizures and 12.6% for all seizure types. In focal onset seizure, median percent reduction from baseline to the end of treatment period in focal seizure frequency for 28 days was 60.4%. And in 50% responder rates, that is 50% responder rate means at least 50% reduction in the seizure frequency. And in total population, it was around 55.4%. And in 6-month completer cohort, it was 57%. In 12 months, it is around 61% were 50% responders. And after 2 years of completion of treatment, around 64% patients had 50% reduction in seizure frequency. And 75% responder rates were 75% reduction in seizure frequency. It was around 48.8%. In 6-month completer cohort, it is around 40%. Patients who received a drug for around 12 months, they responded around 75% reduction in seizure frequency was 44%. And after a 2-year treatment, around 48% had 75% reduction in seizure frequency. Median reduction in from baseline in focal onset seizures, 50% and 75% responder rates were numerically higher in patients within the focal onset seizure population. So the 1 month to 4-year age of children had better outcomes, better reduction in seizure frequency compared to 4 to 18 years of age. A similar pattern was seen in as analysis by other completed cohorts. So around in focal onset seizure population, 34% in 1 month to 4 years of age had greater than 12 months seizure freedom. And in total number of focal onset seizures, around 30% had more than 1 year of seizure freedom after 12 months of treatment. And in generalized seizure population, it is around 24%. In 12-month completer cohort who received at least 12 months of treatment, so the 12-month seizure-free period was 12.7% in focal onset and 14.6% in generalized seizures. And for the patients who completed a 24-month treatment, so 32% had a seizure-free period of 1 year, and 25% in generalized seizure had a seizure-free period of 1 year. Coming to the clinician's global impression of change, around 75% of the patients have showed minimal to very much improved, and only around 1 to 2% have showed worsening of symptoms, minimal to very much worsening of symptoms, according to the clinician global impression of change. And around 17.4% of the patients had no change after starting lacosamide. According to caregivers' impression, around 76% of the patients had showed minimal to very much improvement, and around 7% has showed worsening of the symptoms. Around 16% has showed no change after starting lacosamide treatment. Coming to the adverse effects, adverse effects are defined as any effect that has any including drug-related TS, serial adverse effects, pyrexia, upper respiratory tract infection, nasopharyngitis, vomiting, and somnolence that have come after starting the drug. So most common side effects include pyrexia, upper respiratory tract infection, vomiting, and somnolence. Drug-related adverse effects in focal onset seizure were seen in 31% in focal onset and 27% in generalized seizures. Serious adverse effects were only seen in 31% in focal onset and 27% in generalized seizure. Drug-related TES were seen in 21% in focal onset and 8% in generalized seizure population. Pyrexia was one of the most common complaint, 27%. Vomiting was around 29%. Irritability, aggression, and insomnia were reported in very few patients, in less than only around 2.1% of the patients. So for Achenbach CBCL, a mean line from baseline to last evaluation was to 25 months for 1.5 to 5 years, and for 28.8 months for 6 to 18 years of age. At last evaluation, most patients remained in their baseline T-score category. Of those that has changed the category, a generally similar population of patients showed improvement. So most of the patients category has unchanged around 77 to 80% in almost all the categories. And normal to baseline clinical range, there is around 9.7 to 9% in most of the cases. And most of them, and a similar number of people from 8 to 12% have changed from baseline clinical range to normal. Behavior rating.
Dr. Pavan?
Sir?
Sorry for asking this if I have not missed. Have we already explained what the Achenbach CBC and T-score? Can you add something, or would you like to comment it after the presentation or something like that, sir?
I'll tell now. At the starting, I told about Achenbach BCP.
Yeah.
I told at the starting, sir, about that basic scoring. I told.
Yes. Okay, please continue.
So brief behavior rating inventory of executive function, and its preschool version is brief P. Our standardized questionnaire designed to assess the executive functioning in children and adolescents in everyday settings. These tools are widely used in clinical, educational, and research settings. And they include inhibition, shift, emotional control, self-monitor, initiation, working memory, task monitoring, and organization of the materials. And the validity score is negativity, infrequency, and inconsistency. So these are usually the respondents are patients, teachers, or clinicians who can see this. And it consists of around 86 items on a 3-point scale: never, sometimes, and often. And a scoring is given based on this, and a T-score of less than 60 is normal, more than 65 is clinically significant, and 60 to 64 is borderline. So most of them remained in the baseline T-scale range. There were no major issues with the drug. Once the lacosamide started, there were no major behavioral issues. Almost all remained in the baseline range. There were no major concerns. Only in one case, there is a minimal effect on social functioning around 1.2% people. Otherwise, everyone remained normal. Discussion in this analysis of a large patient pool from 2 long-term open-label trials. Adjunctive lacosamide treatment is efficacious and generally well tolerated in pediatric patients. Overall trial completion rate was 71% with 1-year retention at 80%. In focal onset seizure, clinically relevant reduction in seizures was observed. Efficacy results were generally consistent with previous short-term 6-week and 10-week maintenance. Overall, 82% of the patients experienced the adverse effects, 31% had drug-related, and 5.9% discontinued due to the adverse effects. The most common adverse effects were pyrexia, upper respiratory tract infection, nasopharyngitis, vomiting, and somnolence. However, the above side effects were also among the most frequently reported ones in long-term label trials of adjunctive LCM in adult patients also. Children with epilepsy are at increased risk of cognitive and behavioral problems. Although many ASMs are available for using in pediatric populations, some have been associated with negative outcomes on cognition and behavior. And during lacosamide treatment, the behavioral and emotional function was generally stable in patients and slightly improved in more than 6 years of age group. Executive functioning was stable in less than 5 years of age and generally slightly improved in 5 to 18 years of age. Health-related quality of life generally showed small positive numerical changes in most of the subscales, with consistent small improvement across all age groups in emotional function. And clinicians and both caregivers reported improvement in 76% of the patients during lacosamide treatment. Results from the individual trials were generally aligned with the findings from the pooled analysis. And conclusions, the results of this pool analysis of data from 2 large open-label extension trials showed that long-term adjunctive lacosamide treatment was efficacious with clinically relevant greater than 12 months. Freedom rates and generally well tolerated. Behavior and executive functioning were generally stable without observable worsening. Improvement during lacosamide treatment was reported in more than 75% of the patients by both physicians and caregivers.
Thank you, Dr. Pavan. That is an excellent presentation. Thank you for describing everything very well, especially showing us the questionnaires and the behavior checklists, etc. So now we will go to the analysis part, which is done by Dr. Nikitha. To fill in this article appeared in Epilepsy and Behavior, the journal, in August 2024, published by Elsevier. In 2013, the impact factor was 2.061. Over to Dr. Nikitha for the analysis. Dr. Nikitha. Nikitha, I think we'll have to unmute and probably. Dr. Nikitha?
Yes, sir. Yes, sir. Sorry.
Please continue. Thank you.
Good evening, everyone. I'll be doing critical appraisal of the article now discussed, that is long-term efficacy, safety, and tolerability, including behavior and executive functioning during the adjunctive lacosamide treatment in the pediatric patients with uncontrolled epilepsy. So as this is a pooled data and open trial, one second. Yes. So I will be using the strobe analysis for the appraisal. So the strobe analysis includes the following things to be assessed, that is title and abstract, introduction, methods, results, discussion, and other information. I will be discussing each of them in the following slides. Title and abstract. In the title, whether it is reflective of the study question, yes, it is reflecting the study question and also the study outcome also. So the efficacy, safety, tolerability, including the behavior and executive functioning is reflected in the title. Study population is also mentioned, that is the pediatric patients with uncontrolled epilepsy, but the study design has not been mentioned in the title. Abstract, as already discussed, it provides an informative and balanced summary of what was done and is also found. Then in introduction, the background, it explained the scientific background and rationale for the study to be done, and the objectives. So does this article state specific objectives, including any pre-specified hypothesis? This article states the specific objectives which it want to evaluate. That includes the long-term efficacy, safety, tolerability, behavior, and executive functioning in the age group of more than 1 month to less than 18 years with focal seizure as well as generalized seizures. And the data is enrolled from 2 open label long-term follow-up trials. But as this is an observational study, there would be no hypothesis. And methodology. Among methodology, the following headings should be discussed. That includes study design, setting, participants, variables, data measurement, bias, study size, quantitative variables, and statistical methods. So the study design, it is so observational study. Basically, we are taking the patients, observing them from the 2 open trials, that are SP848 and also EP0034. And the setting is multicentric setting, and recruitment period, it is not mentioned in the article or the supplementary material provided also. And follow-up period mentioned was maximum of 2 years the children were followed, and the data collection was from the pooled data that was obtained during the regular visits. And the participants. So in the participants, we should know about the eligibility criteria and the sources and method of the selection of the participants, and how they are followed up. And in this, the eligible exclusively inclusion and exclusive criteria, they have not been mentioned in the article, but the supplementary material provided has the inclusion and exclusion criteria. As we can see that patients who have previously participated in the 0847 trial have been included, and also or the patients who participated in other lacosome pediatric trials in epilepsy could enroll in this SP848 trial. That will depend upon the opinion of the investigator who is expected to benefit from the participation. If the investigator feels that there is benefit from the participation, he will include the subjects. Also, other inclusion criteria have been discussed. Also includes uncontrolled focal seizures after an adequate course of treatment. Even that course of the treatment will be determined by the investigator. And also, and the exclusion criteria includes any side effects in the previous trials also have been excluded in this primary trial. Maybe even if we take also, it would be difficult for us to follow up the subjects over the period of 2 years. But still there is a bias here of excluding those people, because the safety profile will be increased by excluding those people. And also direct enrollers, as we have discussed, they were excluded if they have ever received lacosamide previously, or there has been a medical condition or a psychiatric condition, in the opinion of the investigator, that could have jeopardized the patient ability to participate in the trial. And the exclusion criteria for direct enrollers include known any hypersensitivity to the component or the ECG abnormalities. And the participants have been classified into focal onset generalized population. And again, the focal population has been divided based on the age into 1 month to 4 years, 4 years to 18 years. And again, the completer cohorts, they have been defined as the subsets who have received lacosamide for a specific duration of the time, which have been already discussed. and following scales have been used. And variables. So in the variables, we need to check whether they have clearly defined all the outcomes, exposures, potential confounders, effect modifiers, if any diagnostic criteria. Outcomes, they have particularly mentioned these 7 things they have measured it. That is the retention rate by Kaplan-Meier scale, median percent reduction in focal onset seizure frequency from baseline, 50%, 75% responder rates, clinician and caregivers global impression of change, and also treatment emergent adverse effects, 12 ECG results, and also other checklist scores have been used. And exposures. In this current study, lacosamide was used as an adjunctive treatment to the already existing anti-seizure medications. And confounders in this study, they did not particularly disclose any potential confounders, but usual confounders in any epilepsy treatment could include factors like age, comorbid conditions, and the concomitant anti-seizures medication used, and the effect modifiers. And this also has not been defined particularly, but potential modifiers from this could be, we only got to know whether it is a focal seizure or generalized seizure. Among generalized also, whether it is a tonic, clonic, myoclonic only was described. But they haven't described any particular type of the epilepsy syndrome or the medical that would affect the drug choice also. And associated medical conditions can also affect the response, and also genetics of the child, and also other anti-seizures medications which have been used that could interact with the drug used. And the diagnostic criteria for the uncontrollable epilepsy, they haven't particularly said any definition, but according to the inclusion criteria, they have included the children with more than two or more anti-seizure medications, either concurrently or sequentially, and 2 or more countable seizures in a 4-week period before screening, and a stable dosage regimen of 1 to 3 anti-seizure medications. So it need not be that child should be on 2 ASMs concurrently. It can be sequentially also. So the stable regimen of 1 to 3 anti-seizure medications were taken, and data has been measured. Bias. Others, they do not acknowledge any bias, but potential biases in this study we could identify were, it is an open label study. So both the patient and the investigator know the intervention. And also in the inclusion criteria, we could find that the inclusion of the patients have been decided based on the opinion of the investigator. So selection bias is there. And patient with side effects in the previous trials were excluded. So here the chance or the percentage of the safety set will be increased by excluding this side effect, patients with side effects. And some others of the article are employees of the UCB Pharma who has funded this project. Study size. No sample size estimation was discussed in this article. And quantitative variables. So it in this the quantitative variables, mainly it measures the efficacy and also safety and tolerability. They have been quantitatively measured by using retention rate, median percentage reduction in focal onset seizure frequency from baseline, 50%, 75% responder rates, clinician and caregiver global impression of change. Safety and tolerability, they were measured by using treatment emergent adverse effects, ECG results, and also other checklist scores for behavior and also functioning, executive functioning. And assessing the statistical methods. So first thing is whether they have described all the statistical methods, including those used to control for confounding. They have actually done the descriptive analysis was performed for efficacy and safety assessment. And they have created 2 groups, safety set and also full analysis set. Safety set is for the persons who have received at least one or more lacosamide dose. And full analysis set is done for the patients who have at least completed 1 or more post-baseline seizure diary. As such, they did not give the statistical methods for controlling the confounding factors also. And did they describe any methods used to examine subgroups and interactions? No. And did they explain how missing data was that addressed? No, it was not addressed in this article. And does they describe how loss to follow-up was addressed? Actually, they just mentioned that the trial completion rate was 71.7%, and proportion of the patients in the focal and generalized seizure population, they have discontinued the trials. So around almost equal, around 5 and 6% respectively, and lack of efficacy. So few of them have discontinued due to lack of adverse effects, and some of them have discontinued due to lack of efficacy. Only this much has been described, but not much has been addressed. And did they describe any sensitivity analysis? No. And in the results for the participants, so report number of patients at each of the study, example numbers potentially eligible, examined for eligibility, confirmed eligible, included in the study, completing follow-up and analyzed. From this chart, we can just know that which phase trials were the previous trials. Some are open label and some are double-blinded phase 3 trials. And from that, we have got the patient included into this. And in this, they have again made into safety set and also full assessment set. In safety set, that is who have received a single dose were 905 patients, and full assessment. So they were 901 patients. So maybe probably the 4 patients, they have been lost to follow up, maybe due to adverse effects or lack of efficacy. And from that pool, again, this focal seizure and generalized seizure, they have been pooled. And again, that has been discussed. And they did not give any reasons for non-participation at each stage. And did they consider use of a flow diagram? This is the flow diagram provided by them. And descriptive data, they have given, did they give the characteristics of the study patients like demographic, clinical, social, and also information on exposure and potential confounders. So demographics have been given like age, racial group, epilepsy history, and seizure classification and all. But as such, there was no information on the exposure and potential confounders. Do they indicate the number of patients with missing data for each variable of interest? It was not acknowledged about the missing data for each variable of interest. And did they summarize follow-up time, average, and also total amount? So they have just told that summarize the follow-up. We have followed, they have followed up for 6 months, 12 months, and also 24 months. That was done. And overall 64.2% percentage of the patients, they have completed 24 months of the treatment. So this percentage of patients have been followed up till 2 years post into the treatment. And outcome data. Yes, they have reported the outcome events and summary measures over the time, and in detail it was explained by Pavan. And discussion key results, did they summarize key results with reference to study objectives? Yes. And limitations, article, it does not mention any limitations, but potential biases we have discussed in the previous slide. And lack of control group also, because it is an open label study, there is no control group, and it is an observational. So there is no either placebo or active comparator group. So we could not really emphasize that lacosamide has caused this positive effect. And interpretation. Overall, the study results are promising, but more research with controllers is needed for knowing the potential role of the drug. And generalizability. Although it is an open extension trial, because of the large population studied and relatively good retention rate mentioned by them, and more tolerability with mild side effect profile and also less behavior changes, it can be tried for focal seizures. But we have seen that the generalized seizure population is not well represented, and it should be used with caution. And other information provided by them are whether it was funded or not. So it was funded by UCB Pharma, that was involved in the design of the trials, post hoc analysis, collection, analysis, interpretation of the data, manuscript review, and also decision to publish the manuscript also. And some of the authors were employees also. They were responsible for data interpretation, revising the manuscript for intellectual content, and also approving the manuscript for submission. And they have conflict of interest that includes They have the financial interest and also personal relationships with the pharma that has funded it. First two authors, which are the main authors, they have no conflicts of interest, but the other people, they were the employees and they have received some financial this support from them, and some are the salaried workers among them. And take home message from this is it is an open label study, so we have the performance bias also, and we don't have any controls to emphasize that this drug has the role, and variability in the baseline seizure frequency among the patients. In epilepsy etiology, no particular syndrome has been described, and associated medical conditions and prior AS anti-seizure medication regimen, they can affect the outcome of the patients, and the result of the medication usage. And concomitant anti-seizure medications which were administered, and their interactions couldn't be assessed in these patients because there was no placebo or controls to be comparing. And if they would have placed the placebo controls, that would have helped us identify. And checklists used in this they are prone for expectation biases, as they are subjective, done by the investigator and also the caregiver. And the study reported 80% retention rate, but the discontinuation due to adverse effects could skew the results towards more safety profile. And lack of control group makes it difficult to attribute improvement solely to the lacosamide. But although it is there, but because of large population studied and relatively good retention rate and more tolerability with mild side effect profile, lacosamide can be tried for focal seizures. Thank you.
Thank you, Dr. Nikitha. Can you stop the screen sharing?
Yes.
So both the pediatric neurology practitioners have presented it excellently well. Dr. Pavan presenting how the study was conducted, the statistics and the outcomes in a brilliant way, and Dr. Nikitha has cleared the doubts. The doubts which arises in one's mind when one reads the article, as well as additional pitfalls, and has dissected with great precision. Now we will like to hear from Dr. Ramkuti sir regarding the article, the presentation, and everything. Over to Dr. Ramkuti sir.
Okay, so good evening. Can you hear me?
Yes, sir, we can. Please continue, sir.
Okay, I thought the article was not very complicated. It was pretty straightforward, and the presentation was good. I mean, they did a good job, very excellent job, I would say. Both the person who presented the paper as well as the critique. Actually, this is a follow-up, or like you have a trial and then you follow up the people to see whether there are side effects or further complications and how they do later in life. And I think that's very important for a drug which is an anti-epileptic, because it's a lifelong medication probably for many people. So that's I think it's a major important problem in pediatric neurology. I'm not an expert, so I don't know, but I assume that it should be a very important aspect of practice, because you will have these people coming to you again and again. So this kind of study is important, and I think so that way it was a very good choice. And I don't know whether methodologically there is any challenge. They have presented as, I mean, the study has been done pretty well, and the presentation has also been very well made, and they have explained everything. The only problem I had, I don't know, I just read the paper, I mean, I did go through the whole paper, but they have been like, they're not very clear about what certain things. For instance, Dr. Nikitha also said that they have not set the design of the study, and I would put it as a cohort, because they are following up people who have already been in trial. So it is not really a trial, because, and so she rightly looked at the STROB, because it is observational study. So they are being observed for a long time. So that way, that is a perfect choice. But they have not mentioned that in the design part. And they also have not mentioned, for instance, suppose you do a study and they follow up the people, and did they follow up only those people in the treatment arm, or did they follow up also the controls? That is not very clear. I think from what Dr. Nikitha presented, I think it is assumed that the follow-up did not include the controls of the original trial, if at all they were there. So that, I mean, that part is not very clear. I could not really make out what to. I mean, if anybody has an insight into that, you can please enlighten me. But she did point out that that is a flaw in the study. Probably it is. Probably because you have a trial, you have people who are part of the test group who are accepted, who are getting the drug, and probably you think only they need to be followed up. I think that's natural. So you don't need to follow up people who are in the placebo group or the control group. So probably that she has made a very valid point that they did not have anything to compare with. It's just a follow-up of people who are in the trial and who got the medicine. I think that way, but in this design, it is very difficult to see how it could have been different. So that is the problem. So sometimes, I mean, of course, no study is perfect. So you have to do the best of what you can in the available situation. So that way, I don't find a problem with that, but you can raise it as an issue. I mean, if anybody has any question about methodology, I will try to answer. Otherwise, I think it's a straightforward kind of study. And I don't know whether this drug is extensively used in India or whether, and also what age group we are.
Yes, sir. We'll come to.
So I think.
Yes, sir. Definitely we'll come to that, sir. Thank you for your.
Yeah, those
thank
things
you for your.
and I would like to know all that because I'm not a practicing clinician. So.
Yes, sir. Before we go to, we have the subject experts with us, mentor also, but we have Dr. Rajmohan sir also here. Before going to the clinical aspects, we would like to hear from Dr. Rajmohan sir also. Dr. Rajmohan sir.
And you just ask Karthika for that clarification regarding the use and all. And
yes, definitely, madam. Definitely, madam. Please.
So regarding, so Rajmohan sir is speaking, I guess. I think I will answer.
No, I think.
Yeah, you just clear the doubt.
Yeah, Rajmohan sir. You will come to the clinical part, madam. Dr. Rajmohan sir. Sir, you are telling something, sir? Okay.
Good evening, sir.
Madam,
good evening, Rajmohan sir.
Yeah, please.
So lacosamide, as in this particular study, it's used as an adjunctive treatment. So we often give it as a primary treatment for focal onset seizures and less so for generalized seizures. If we are using for generalized seizures, most often adjunctive treatment. And for this study, lacosamide has been used as one adjunctive treatment, second for uncontrolled epilepsy. So lacosamide is a foolproof drug for focal onset seizures, and we use it on a regular basis. Actually, after coming to KIMS, I've seen Kalpana ma'am using it very commonly, and it is definitely a proven choice of drug for focal onset.
So it is available here, and it is not very expensive also. Is it not so bad? It's not very expensive, no?
No, in this there is a there is a kind of a distinction between the FDA and the European recommended age group. So what do we follow?
So what? Yes. So the CDSCO as such has not shown for any proof for less than 4 years, but after 4 years, efficacy is well established.
Okay.
And we are doing the same now. Yeah.
Yes. But even for less than 4 years, we are giving it, and it's showing good improvement.
It is accepted actually
Okay.
from 1 month. From 1 month onwards, actually, it is approved by the US FDA. Not for us, actually. In CDSCO is not mentioned.
That's what I'm asking.
That they also have used patients from 1 month onwards in this study, isn't it? 1 month of age. And it is shown that it is more efficacious in the younger group. That is what is shown.
Okay.
And regarding this newer anti-epileptic and old anti-epileptic drug, actually, focal onset seizure, when we hear about focal onset seizure, we'll be thinking of carbamazepine or oxcarbazepine and phenytoin. These are the drugs that we used previously, and they are still very effective, that I can say. The problem is with the side effects, mainly carbamazepine, because the Steven Johnson syndrome, when it comes, it is a very severe menace. That is why the carbamazepine has come down in the list now. But definitely, as per the effectiveness or seizure control,
Oh, some problem.
I think some net issue is there. I request everybody to be patient for a few seconds, maybe.
but the side effect profile is relatively better. And carbamazepine also has a problem with cognitive and behavioral problems. There can be problems, and there is said to be some with the problem with learning also. That is why this behavior checklist has been done. The problem with this study is actually in children with epilepsy is a very diverse group, and they have different types of prognosis. Some are very benign. When you are taking this infant, there is a group called benign infantile seizures. Any sodium channel blocker, most of the drugs, it will be effective. And there is a age group beyond which the patient becomes seizure free also. And there is another group which will be very, very resistant to seizures as with all the drugs. So which all patients they have selected, and so now the epilepsy syndromes is coming up in a big way. Like when we say about one epilepsy syndrome, that will be having a very bad prognosis, another one have a very good prognosis, and when we take all of these together, it will become a actually initially when the drug was started, it was used as an adjunct treatment, as Karthi has said, in uncontrolled epilepsy, and now actually are using it as the first line treatment also, as the first drug. So when we are using it as adjunct treatment, the efficacy will be less because it's a resistant type of seizure we are using. But when it is using as a first drug, we will get a better response. That is natural, isn't it? Adjunct treatment, actually, some drugs are enzyme inducers, some are enzyme inhibitors, and so the bloods all can change. And this drug, the blood level is not being measured nowadays because it is not yet come. The previous drugs, the older drugs, we have measures to check the blood levels. So valproate is an enzyme inhibitor. So with valproate, with small doses, there may be good response. Like the drug level of lacosamide will be higher when we use valproate. Like that, there are drug interactions also is one thing. And when it is used as an adjunct treatment, patient is having on some drugs which are having problems with behavior, that will also affect the result. So, but because it is a large group, maybe it may be somewhat balanced. So that is the thing. And this is the continuation. So we cannot tell about the selection bias because they were telling that the investigator is selected based on their personal opinion whether this drug will be effective or not, and those with the serious problems were excluded. That naturally can be done only in that way, because if there is serious side effects, we cannot continue the patient on that drug. So that were removed, but long-term retention of 80% is a very good. Okay, Sir Rajmohan sir, regarding Rajmohan sir. Rajmohan sir is there?
Yes,
yes,
I don't.
Start to speak.
See, Kalpana, epilepsy research is a very challenging area, especially the drug developments, because if you look into the drug trials in epilepsy, whether the trial-based evidence is sufficient enough to change the physician practice behavior is a real question there, because other empirical evidence is a lot. But if you look into the different trials, the methodological issues are very, very complex. For example, you mentioned the diverse nature of childhood epilepsy. See, how to accommodate the heterogeneity in comparison is a real problem. And another issue is definition issues. For example, how do you define intractable nature? Because do you define clinical impression then by EEG changes? And the definition itself includes a lot of measurement bias. And another very important thing is usually you make it in adjuvant. So when adjuvant therapy, the specificity of the drug action is a big issue. So a lot of issues are, it is not that easy. And my only comment is that all that glitters is not gold. Please remember that. But because our life has been always dedicated to learning and teaching methodology, and we have to also find some space. And there is a lot of scope for good methodological designs, especially a lot of adaptive designs, stepwise designs, a lot of modifications of randomized control trial designs are there. Even randomization, the process of randomization is the keystone in robustness of evidence in interventional research. So a lot of modifications are there. So there is a scope for conducting a proper study. I'm not very much impressed with this study. I don't know. I am a little confused. I wanted to ask Ramguru sir also, because pooling of data in the context of a evidence synthesis is okay, but pooling of data just to increase the precision and power, I don't know how far. Because somebody has done some studies, you just take 2 studies, the data, and individual level data. There is some concept called individual level meta-analysis, IDP meta-analysis. So these are all some of the very debated topics in clinical epidemiology. So I don't know, I am here learning. But one thing I am very sure, there is a lot of scope for conducting a very good, because once we thought that randomization of refractory or status epilepticus or random refractory seizures is difficult. But now that concept has gone, because there are a lot of adaptive designs or adaptive trials. Originally, we had only crossover designs or factorial designs or some designs, fixed designs like that. But now, just you say that there are newer epileptic drugs, now there are a lot of methodological advancements are there, like stepwise design, adaptive designs, and a lot of design intricacies have been changed so that we can design definitely a good study. But the problem is that a single center may not have enough number of cases. So we go for observational evidence. Now, the problem with observational evidence is that the evidence is never robust, because the interventional evidence is the state-of-art evidence for interventions. That is experimental evidence. So observation, now a lot of change in those concepts have also happened, because combining observational evidence with experimental evidence is called comparative effectiveness research. Now is the day of comparative effectiveness research. So there is a scope for, so what I meant to say that a researcher or a clinician researcher need not be that pessimistic. There are a lot of methods and scope for doing it. And of course, your conclusions should be based on the data. Here, I've seen a lot of zeros and ones, even after pooling. Because Kalpana has given the answer. It is a very diverse situation. And the subgroups may never get, even after pooling, the purpose of pooling is to increase precision and also get sufficient number in the subgroups. But that also is not achieved. Even in spite of that pooling of a very large 2 trials, that has not been achieved. So this is only a data management or data analytic procedure, a newer data analytic procedure to get into an already given directionality of endpoints. They have some agenda, because it's a funded study trial. They have some agenda. So anyway, but my only humble suggestion is that it's a very challenging field, but there is a lot of scope for conducting very good studies. Karthia, especially like Karthia, and my advice is, because Karthia is one of my students, my advice is Karthia, get into the methodology, study. You can, in the world, if you look, the best epidemiologists are always self-made epidemiologists. They are not persons with formal educational degrees or things. So there's a lot of, it is only common sense. So you can get into that. Please get into it. Try to conduct a very good study, because you are the center where maximum number of interactable cases will come. Of course, I don't know about children and adult difference, because the basic etiological reason of interactable nature in adults and seizure may be almost identical. I think, I don't say same, but maybe identical. There may be some triggers. So you can analyze at separate groups with a large multi-center trial. So I hope you can take the initiative and apply to ICMR or somebody. Okay, thank you very much for giving me the opportunity. Our other methodological aspects are very well, so I don't have anything more to add. Thank you.
Thank you, sir. Thank you, sir. Before going to Patnam, sir.
Can I just say one
Yeah,
sentence?
please, sir. Please, sir.
I don't think it is a meta-analysis. I mean, this is not at all meant to be a meta-analysis. It is just a follow-up of people who have been on a trial, and what they're trying to do is to show that these drugs in the long term are safe. And that is, I mean, they may have their own agenda, that is different, but criticize it on the point that it is not showing efficacy. I think it is going beyond the call of the study. I mean, you can always criticize anybody.
They have not communicated what design it is. They have only pulled 2 studies and they have analyzed.
And not pulled, they have followed up.
Followed up means, sir, sir, follow up. Follow up data retention rate.
Yeah, right. They have looked at the follow up data.
Looked at the follow up data. That is all. They
Yeah,
have not. Other, I don't know what method you can say that design you can say.
To me, it is a cohort.
That depends on, because cohort is a primary research design. Here they are doing it with somebody else's data and looking to that.
Is it somebody else's? I don't know. I'm not sure.
No, they themselves have taken actually.
Yeah.
They have taken the trial, sorry.
Kalpana, it is a study of studies. Two study data analyze
അങ്ങനല്ല ആ ഇൻവെസ്റ്റിഗേറ്റേഴ്സ് എല്ലാം ഇതിനകത്ത് തന്നെ ഉണ്ട് നോക്കിയതാണ് അങ്ങനെയാണ്.
Okay. Anyway, I don't know because ഇത് ഒരു typical because exposure follow-up study, cohort study എന്ന് പറയുമ്പോഴത്തേക്ക് ഒരു 0 ടൈം വേണം. കുറെ ഒരുപാട് മെത്തഡോളജിക്കൽ ഇഷ്യൂസ് ഉണ്ട് അതിനകത്ത്.
ഹലോ രാജ്മോഹൻ, റെട്രോസ്പെക്റ്റീവ് എങ്ങനെ നിങ്ങൾ ചെയ്യുന്നത്?
റെട്രോസ്പെക്റ്റീവ് കോഹോർട്ട് അനാലിസിസ്
ഹിറോഷിമ കോഹോർട്ടൊക്കെ ചെയ്യുന്നുണ്ട്. അതിപ്പോ അന്ന് തുടങ്ങിയൊന്നും അല്ലല്ലോ, ആണോ?
അത് നമ്മള് അത്തരം, കാരണം ഇപ്പൊ ഈ ഹൗസിൽ അങ്ങനെയുള്ള മെത്തഡോളജിക്കൽ ഡിബേറ്റിലേക്ക്
ഞാൻ പറയുന്നത് ഇത്രേ ഉള്ളൂ. നമ്മൾ അവര് പറയാത്ത കാര്യത്തിനെ അവരെ ക്രിട്ടിസൈസ് ചെയ്യേണ്ട കാര്യമില്ല, ഇത്രേ ഉള്ളൂ. It is like Don Quixote, going against the windmill, അത്രേ ഉള്ളൂ. ഞാൻ ഒന്നും പറയുന്നില്ല, ഞാൻ നിർത്തി.
I don't find it as a typical cohort study. അത്രേ ഉള്ളൂ.
Anju,
they also have not.
Yes, sir. I was coming to you, sir.
Can ordinary people also interact?
Please, sir. Sir, I was coming to you, sir.
No,
please,
I think my interaction probably will be useful in 2 ways. One, we will reduce the friction status, and secondly, I want to ask. Can I ask something?
This is one of the most healthiest, interesting discussions.
No, can I?
They are all standards.
To Pavan, he said that among the adverse reactions, it's a clinical question, basically from a clinician point of view. 25% had fever. So that was related to the drug, or it was basically the child has an incidental fever. So it's a very high percentage. 1 out of 4 children who are on this cohort study. I would say cohort study, hopefully. That is one point. Second point, ECG was taken in all patients. No, so I just want to know, being a cardiologist, what was the purpose? And the third, because being an epidemiological study, what percentage of this co-authors and all approximate percentage of people who were employed by the UCB. So 3 points. So
Dr.
can
Karthika, madam,
Pavan
can-
or Nikita try to help
Yes,
me?
please.
Yeah. Nikita is there?
Ma'am, yes, ma'am.
Tell. Please answer sir's question.
Sir, lacosamide, it is a sodium channel blocker, sir. So it has been shown that there is a effect on the cardiac, sir, causing PR prolongation, atrial fibrillation, and arrhythmia, sir.
Okay, so that
So
is
for that,
that's right. Another one is that fever. He said mentioned 25%.
yes, sir, that is an incidental, sir. Even after 1 day after starting the drug, also if the child develops, it is treatment associated adverse effects, like that.
Treatment
Okay.
emergent adverse
Emergent adverse effects, sir.
That's all. Okay. Then so it's not like a prostaglandin producing fever. It's not a drug induced fever.
So
right?
they have mentioned that because this is a pediatric population, the treatment, the fever, nasopharyngitis, common cold, all were mentioned among the
Okay.
minor adverse events, which
Mhm.
they also
Then,
have not done.
Yeah. Then third point, Kalpana, I mean, Nikita, then focal, what is the difference between focal and focal onset seizure? No, honestly. Is there a difference? Yes, right?
Sir, actually, this ILA classification is being changed, and the terminology is also being changed every few years, sir.
Okay.
So
I get the point, but tell me what is the difference?
Sir, general what we see, like the focal, we will take focal seizure if one part of the body is involved, like that, sir.
Okay.
Focal onset, if we talk in a deeper sense, like the brain, there is a focus, and from there it is generating.
Here the study was both on focal onset as well as generalized, right?
Yes, sir.
Yeah. Okay, thank you. Thank you.
This focal onset is the thing that is in, because the focal onset, previously we thought that when it is generalized, it is coming from the central part like the thalamus and is spreading bilaterally. Now the thing is, some areas of the brain, when it is involved, it can rapidly spread bilaterally that we cannot even say that it is we will think it as a generalized seizure, but there may be a focal onset even for the generalized seizure. So that idea is coming with the more and more studies and all. Sometimes when we say generalized, also with the surgery, removing a small part, there may be a benefit with surgery also. So now the onset, where is the onset is the point. That is why this focal onset word has come. So it's not a simple thing. It is a very, very complicated thing. It is becoming.
Okay, accepted. Thank you.
Thank you, Sufika sir, so much.
Anju.
Now to Dr. Padmanabh sir. Sir.
Yeah, I mean, this is as a pediatrician for nearly 40 years. In the first 30 years, probably I would have managed many epilepsies, and then I would have stopped managing resistant epilepsy when the neurologists come in. I have been using carbamazepine and oxcarbazepine in Gulf for many, many years. I ran a neurology clinic. I never saw any side effect with them, even agranulocytosis, nothing like that. Well, my question is now Dr. Kalpana, I understand, is giving lacosamide as a first drug of choice. Now, when you give a first drug of choice, what will happen when a pediatric neurologist starts doing it? Everybody else will follow it. That's what I have seen here. I'm sorry to say this. Many of the young pediatricians here, if you ask them, why do you give it? He will say, this is given by Kunjan sir, this is given by Sulfika sir, we are giving it. Have you given a thought to it? No. Now, my question to you is simple. Has any of the guidelines say that the first line of drug for focal seizures, even in the beginning, is this, or only for resistant seizures? And I have not read much about this medicine, but I heard the PG telling that it can cause atrial fibrillation and all that. Therefore, is there a comparison between the side effect of oscarbazepine, established medicines which have been used for a long time? Naturally, the side effect would be more. You will know it, and this is a new medicine. The side effect will come up after. Side effect of the toxicity will come up later. Therefore, I would ask Dr. Kalpana what makes her change it to this new drug.
Sir, the first and foremost will be regarding allergy. Allergy is a problem. If it comes, it is a very severe Steven Johnson. Even patients have lost their vision. And in SAT, we had once in a while. Initially, previously, we were seeing all due to Septran, isn't it? When it was previous Septran or Sulfa. And after some time, that is in the 2000, 2010, like that, if at all the child is Steven Johnson is admitted, most probably it will be carbamazepine. So the drug allergy, Septran also has come out of use because of the drug allergies in it. Because now it is the time for this consumer thing, and they will even sue against you if there is. And now it is actually like you have to do the recommendation is you have to do the HLA typing to see, because in certain HLA phenotypes like 1502 and all, there is an increased chance for carbamazepine allergy. That is in Chinese population as well as in Asian population it is mentioned. So that is one. And the second one is the cognitive side effects are also mentioned. And after carbamazepine, the oxcarbazepine has come. And compared to carbamazepine, oxcarbazepine, the allergic reactions were less, but it was there. And we saw that there are many patients who develop hyponatremia also with the oxcarbazepine more than carbamazepine. And cognitive impairment is said to be less with oxcarbazepine. So then lacosamide came. Lacosamide is a drug which is a very safe drug in the sense that even though the cardiac adverse effects were mentioned, there are even in this large study also the cardiac adverse effects were very, very minimal. And so the cardiac adverse, now we are not doing ECG before giving lacosamide because that is said to be of no need like that. So there are comparison studies between oxcarbazepine and lacosamide. Regarding the seizure freedom, it is not much ahead, but regarding the efficacy, and another thing is an injection is also available. We can load also, even it can be used in the time of status also. And so injection is available, and the side if we can use a relatively we can make up the dose faster. The other one we will be using in 1/4 dose and slowly building up the dose. So then there are many, and these SLE-like symptoms, the Trust syndrome is there. These all come occasionally when we use it. So for so many patients only, sometimes we may know. There are definite side effects with the drugs.
My question is regarding the cost, which is more costly, and something else I want to ask.
That is definitely, cost is definitely much. Like one carbamazepine may cost some 4 or 5 rupees. This one may be costing some 20 rupees.
Yeah.
Tablet.
Because one of the factors which Manguti, I don't know the name of the effect, the more costly the drug,
the thing
the
is,
more the
it depends on the place where we are actually. If a person is not worried about spending the money and they should get the best result, we will be definitely going for that.
Okay, now one final question. Has it come with any guideline as Indian neurologist, pediatric neurologist, or any IAP said that the first
as a single drug, there are many studies that are available, sir. As the
Does
first
it come in the guidelines? I'm asking you. Has it come in the guidelines?
It has not come in the guideline phase, but definitely the levetiracetam also has come as an adjunct, isn't it? All the new drugs have come as an adjunct medicine only, and later on it has come in the primary level.
Okay.
Okay.
So this one is a slow sodium channel blocker. One part of sodium channel only is blocked. So that is the mechanism. There is a difference also.
So how long have you been using it, Dr. Kalpana? How long have you been?
This has been available from 2019. Some 6 or 7 years it is there.
Okay. Thank you. So use it as a first drug for partial seizures, is it?
Yes, sir. Nowadays we are using because it is easy to monitor, and side patients, the sedation is less and patients are happy. So hyponatremia is not there. So there are many advantages, definitely.
Okay, thank you. Thank you very much.
Thank you, Patmanam, sir. Dr. Karthikeyan, madam, the mentor and the consultant at KIMS. You are the mentor of the PG Center. Anything more to add, Dr. Karthika, madam?
So that was a very insightful presentation and a very insightful discussion, because from the statistical point of view, multiple points were heard. And from the clinical point of view, also Zulfikar sir asked very relevant questions in terms of cardiac monitoring and everything. Yes, and from what Padmanabhan sir said, it is very important not to forget the older medicines and always question the newer ones, I would say. So, and as a take-home message, anyways, lacosamide can definitely be considered as an adjunctive treatment, especially on the basis of this study, and it is proven to be safe and tolerable in terms of whether it be cardiac or especially for the attention and the behavior part. And
My take
thank you
is
to
that
IIT
I will take it
Trivandrum.
as the first medicine.
Yes, sir.
That's a new news to me, and therefore that's why I asked Kalpana about it. Therefore, if it is so safe from her words, then definitely she has been using for 6 years. Then I will change my prescription. No
And
doubt
this
about
thing is actually in this study they used it for generalized seizure also. It is not mentioned much. Actually, they also have only 47 patients where it is used for generalized seizure. Usually, we use it for focal onset seizures.
Okay, madam. Thank you. And we had
Yeah,
Dr.
and thanks to
Jisi Shibu,
IIT
madam.
Trivandrum. Yeah, and thanks to IIT Trivandrum for giving KIMS
Yeah.
Pediatric Neurology this opportunity to present before this esteemed platform.
It's the other way around.
Madam, yeah, we have Dr. Jisi Shibu, neurologist, also with us. Anything to add, Dr. Jisi, madam? I think madam is not there. Share anything any more points to add, Dr. Rajaman sir? Shall we?
One comment is there in the chat box,
Yes,
Dr. Shija.
Yes, ma'am.
So Dr. Shija is mentioning that underlying cause of focal seizure may have an important bearing on the response to treatment. So that is what is mentioned. Actually, we have mentioned that the different factors, the epilepsy syndrome, the genetics, all were not being considered here in this study. Because as you know, there are many sodium channel SCN1A mutation where we cannot use the sodium channel drugs. And so, and there are many, some are very resistant as the structural pathology, some metabolic conditions are all there, which are different. The epilepsy as such is not a single disease, it's a very heterogeneous. So we cannot say, but when the cohort becomes larger, this will be somewhat balanced. That is only we can say. Nowadays, the genetic basis, without the genetic basis, we cannot even think of childhood epilepsy syndromes. That is
okay, that's true, madam. That's true. The topic is open for discussion. If anything has to, anybody has anything to add or contribute or clear any doubts.
And regarding sodium channel also, the channel SCN1A, the Dravet syndrome, you should not use sodium channel drugs.
Okay,
but in other types, there's type 2, SCN2A, the gain of function mutations, SCN8A, 2A and all, sodium channel drugs these drugs can be used. So that is also, there is a difference. Okay.
Yes, ma'am. Before closing, any closing remarks from seniors, Dr. Rajman sir, anything more to add, sir? Shall we slowly go towards the concluding part, sir? Rajman sir?
I again repeat, it's a very challenging situation to handle everything by a randomization process. So that is again, I am more learned that observational evidence is more important. That is why I just told you, comparative effectiveness research is a new concept where observational as well as experimental evidence is integrated. So that is why we are all going to newer methods. So that is actually needed. Okay, this article also, by just attending this session, I am more convinced about it. Thank you all for making me learned in that way. Thanks.
Thank you, sir.
Thank you, sir.
Thank you so much, sir. Dr. Nikitha, sir, any closing remarks, sir?
No, nothing.
Any, sir?
Can I make
Dr.
a
Pavan
remark
has
here?
talked about-
Can I make a remark here? Small comment.
Yeah, sure, sir. Sure, sir. Please.
See, the only thing is that I would like to say that epilepsy is the second commonest chronic disorder which is seen by the pediatricians after asthma. Therefore, when I was in Gulf, in the particular hospital in which I was there as a secondary care, there was no pediatric neurologist. Therefore, I was forced to run a pediatric neurology clinic, and with epilepsy being the major thing there, I hardly knew even to read an EEG. But of course, I could send it to a tertiary center when I wanted. 80% to 90%, I just managed by giving valproate for generalized seizures. And even for when I had a doubt whether it was partial, I used to give valproate. And when I'm sure it used to give oxcarbazepine or carbazepine, and later on some patients levetiracept. 80 to 90% were treated adequately without any problem. Now the problem here is we are making it a little more syndromic and genetic and all those things. I never felt 1/3 of the seizures were resistant because majority were controlled. Are we we are checking out already the general practitioners are out of the treatment of epilepsy. Soon the general pediatricians will also be out. That's what is done in my hospital also. The first seizure they say, and then they refer it away to neurologist. Well, that I think, I don't know, Dr. Kalpana, is it a good thing that general pediatricians also now go away from treatment of epilepsy? Not only the MBBS doctors, even MD doctors, even DNB doctors are no longer treating epilepsy and following them up.
Sir, what I can say is that if you are very sure that it is an epilepsy, you can give the first drug. But if you are thinking like, actually we are seeing many syncopes are being treated, many non-epileptic events are being treated. So that is the point. That is because it is not like a disease where you are giving medication for 1 week or 2 weeks. It is for years together. So if you are very sure that it is a seizure, and if you can characterize the seizure, and the carbamazepine and sodium valproate, even I can manage most of the seizures. And definitely there are a large group there is a group, like we can say 30% are uncontrollable, because when you are seeing only the patients who are controlled with our treatment, we will think that all are controllable. But when they are going out of control, they will be coming once or twice to the pediatrician, and then they will be going to the next level.
Yeah.
So that is why you may not be seeing that much. Definitely seizure, at least 30% are difficult to control. That is true. But when we
Madam, can I
see
ask
what cohort we are seeing, that is the thing.
Okay,
Madam, one
thank
doubt,
you.
Madam, is clobazam a safe drug for breakthrough seizures of all types of seizures, Madam? I mean, it is a usual phenomenon when a patient on a long-term antiepileptic will throw a seizure and come to the casualty. It is a usual phenomenon, but usually control the seizure. But should we start something, or is it a safe drug to start at that point of time, or should we directly wait? Should we wait till a pediatric neurologist sees the patient, Madam? Sorry for asking this.
The advantage is it's a short-acting drug, so it will have an immediate effect. So if the patient is having recurrent seizures and all, suddenly if you are adding clobazam, the patient may remain seizure-free for the time being. That is one advantage when we are using it in an emergency setting, like one seizure, then the child is improving. After a few hours, one more seizure, and like that. And that is one way, but some rare conditions like this benign Rolandic epilepsy, now we call it a self-limiting epilepsy with centrotemporal spikes.
Yes.
We can use clobazam as a single drug in the night, because the seizures occur only at night. Other than that, we use it as a combination. There are some drugs like carbamazepine. We are adding very small doses of clobazam. The seizure control will be very good. It is said to be like a super additive effect. So clobazam is a very good drug, but it has to be used cautiously. And some patients can have hyperactivity also with clobazam. There are problems, but
Okay, Madam.
you can use it. You can use it judiciously. But in Gulf, it seems it is not available.
No, it's
It
not
cannot be.
available,
Yes,
but
ma'am.
it is, I have learned from the patients that it's very useful for, especially for recurrent
Febrile
febrile
seizure.
seizures, because they smuggle it in with great danger, because if you're caught in the customs, you will be severely punished. Still,
Yes,
the
The
parents
patients
smuggle it in.
get it,
Yeah,
parents get
patients
it
smuggle it
familiar.
in. I warn them severely, don't bring it, but still they will bring it. That means it has been very, very effective.
yes, sir.
Yeah.
Yes, sir. Ramkuta sir, we were actually discussing about, wanted to discuss more about this T-score, hedges, G, etc. But the time is actually already finished and answered. So
Thank
maybe,
you.
sir,
Yeah,
we will discuss that during the next
date. I mean,
sir. Yeah. Yes, sir. Yes, sir. Yes. So, shall we call today? Sulfikar sir also, sir. Shall we wind up the session, sir?
Yeah,
Yeah,
you
I
can call
suppose
it
so.
a night. I can
Yes,
call
thank
it
you,
a
sir.
day.
Yes, sir. Over to
You're
Dr.
in
Srijit.
Canada, sir. You're in
I'm in
Canada.
Canada, therefore I'll call it a day, and you can
Oh,
call
I
it
see.
Okay.
Super.
It's
Dr. Srijit,
11:30
sir.
here in the morning. Yeah.
7:30. Okay.
11:30 in the morning.
11:30.
Which city are you in?
I'm in Ottawa, capital.
Canada.
Capital.
So, let us actually close it for today, and it's already 9 o'clock. So, thank you, the KIMS team, Dr. Pavan and Dr. Nikitha, and the mentor, Dr. Karthika, and Dr. Kalpana Madam for the remarks, and also the extreme faculty and great discussion, Padmanabhan sir, and Sulfikar sir, and Rajmohan sir, and Ramkuti sir. So, thank you for joining us today, and I hope you to see in the next edition of Journal Club. Good night from now.
Thank you, sir. Good day. Good day.
Thank you, Anju, for doing this very well.